So, hello everyone, and welcome again to the Stoke Mandeville webinar series. I'm Rebecca Shirley.
And I'm James Chan.
So we thought it was about time that we have a webinar on artificial intelligence. And the subject tonight is artificial intelligence in plastic surgery, opportunities and risks. And we're delighted to be joined today by three data scientists. First of all, we're going to have a talk from Chris Gibbons, Associate Professor at MD Anderson. And followed by that, Conrad Harrison is here, who is doing his PhD in Oxford. And we're also joined by our very own Jeremy Rodrigues, who is a professor at Warwick University and our colleague at Stoke Mandeville. So the format for this evening is Chris is going to give a talk. He's going to introduce himself and tell you a bit more about himself, and Conrad after that. And I'm just going to hand you over to James to give a poll and some housekeeping as well.
Okay, so good evening. Hi guys. Good to see you all. I've got a poll here and I thought it would be interesting and informative to find out what your experience of AI is in your practice. So here we go. I'll give you 30 seconds to fill that in, please. And as usual, we'll try and make this as interactive as possible. So if you have any comments or questions or anything like that, do just jot them down in the Q&A function at the bottom of your screens, and we'll try and get to them at the end of the talks. And we might even invite you to come up and pose the questions yourselves. Okay, final 10 seconds. 2, 1, here we go. I'll share the results. Okay, great. Fine, okay, lovely. So without further ado, Chris, the floor is yours.
Thank you very much. Hope that comes up okay. So I'd like to take the opportunity today to talk about artificial intelligence and our experience of applying these techniques in plastic surgery, focusing on some of the opportunities that are presented and some common risks that it's worth being informed about. Just to talk briefly about my background, I became aware and began to learn AI whilst I was at the University of Cambridge Psychometrics Centre, whose focus around patient-centered and person-centered data had led to the collection of huge data sets from companies like Facebook, LinkedIn, Spotify, and the NHS. In 2018, I moved to Harvard Brigham, where I had my first experience of applying AI techniques to plastic surgery problems. And a couple of years ago, moved from Harvard Brigham to MD Anderson Cancer Center, where I am now the director of what is called the Inspired Cancer Care Center. And our goal really is to create AI solutions for real problems, particularly those facing or patient-centered care, around the delivery of patient-centered care. So today I'd like to talk about what artificial intelligence is, particularly when we're thinking about its application in surgery, and talk about how it could be used to transform different aspects of surgery and healthcare more generally, and talk about some of the risks that are posed by the adoption of AI, particularly in the short term. Artificial intelligence can be defined as the science and engineering of making intelligent machines, especially intelligent computer programs, and was first described by Alan Turing in Computing Machinery and Intelligence by posing the question, can machines think? Intelligence is a rather vague term, and it can be difficult to understand exactly what artificial intelligence is. I believe it's easiest to think about artificial intelligence as broadly split into two different areas, one being narrow intelligence, or what we refer to as weak AI, and the other referring to general intelligence, or strong AI. The narrow intelligence as it relates to AI is related to computers that are programmed to be able to do a particular task exceptionally well. And there have been lots of examples of computers doing these tasks as well or even better than humans can do them. We interact with these sort of narrow intelligence AIs all of the time via things like Amazon Alexa, chess robots, optical character recognition, any content recommendations that you might experience from Facebook or other social media companies, and they're commonly referred to as machine learning or deep learning techniques. In contrast, general intelligence refers to AI that seeks to mimic natural intelligence, and as such is not constrained to being able to do a single task, but it's broadly applicable to many tasks, much like a human, and is self-learning and developing. And really, there are no great examples of general AI right now. It's mainly still science fiction. One thing that concerns me is the use of AI as a hype term. Where we were discussing the poll question at the start of this talk this afternoon, and we were wondering what you could call AI, and someone cleverly said, Mark Malouf cleverly said, that AI is whatever hasn't been done yet. At some point, AI could have been used to describe a pocket calculator, whereas now it might be used to describe a surgical robot or so. But I believe it allows us to think about things like these science fiction depictions of general artificial intelligence, and that because of that kind of sci-fi imagery of a general AI, it becomes an imprecise term, and it is often used to kind of oversell the potential and ignore potential issues. And historically, this has been the case. Since the 1960s, there have been multiple cycles of overhype AI, overinvestment, overselling on promises, followed by disinvestment and disinterest when the realization is made that those promises couldn't have been met. So we want to take a more sober and measured approach. And in this talk, we will discuss what I refer to as weak AI, or machine learning. Machine learning is simply the process of training algorithms to make decisions using data. It is in many ways comparable to the statistical techniques that you're probably well aware of, such as logistic regression, but is much better suited to the big and messy data sets that we commonly encounter as part of electronic health records and elsewhere in healthcare systems. Uniquely and sort of differently to statistical techniques, machine learning is able to identify subtle nonlinear interactions in data, and I'll show you a very interesting example of that in plastic surgery. And again, we're interested in ML here being able to do single tasks very well, and not being able to self-learn and generalize to different tasks. There is a lot of potential of machine learning in medicine, and I like to think about all the different aspects that could be enhanced using machine learning as those tasks which are within the realms of human capability, and those tasks upon which AI can extend human capability and do things that humans can't do yet. A good example of a task that humans can do very well, but AIs are learning to do well also, is text analysis. And this is becoming an important feature of measurement in the plastic surgery field. Image recognition is another example of something that humans do exceptionally well, and AIs are learning to keep up with humans. The idea being in the future that humans will no longer have to do these tasks, and their time can be freed up to apply more difficult tasks. Decision-making can be enhanced by machine learning, particularly at the frontiers of what a clinician is able to know through their experience. Forecasting, I believe, is something that an AI can do better than humans, and a few studies have been able to show this. More are needed. And also finding these subtle nonlinear patterns in data. So humans tend to think in a very linear way and to have a simple kind of correlational relationship between events and outcomes, and machine learning can overcome that and provide additional information to things that we already had some insight into. Today, I'm going to talk about our use of machine learning AI to understand physician performance and patient experience, to drive decision support for women undergoing mastectomy and reconstruction, and how those models that were developed to enhance decision support in that area have given us unique insights that were not displayed in the current evidence. And I'll talk later about the promise and risk of being able to predict rare events before they happen in plastic surgery. So the first example I'll talk about is about patient experience in plastic surgery. More and more as we continue into the 21st century, we're becoming more interested in patient experience. That is, how patients experience the care that we provide to them. A study we published in Annals of Surgery a few years ago showed that sites and practices that had better patient experience scores had a reduced reduction in important outcomes like morbidity, readmission, and reoperation. One big issue with patient experience, although we're becoming more interested in it, is the standardized questionnaires that we tend to use to measure patient experience. They tell us what patient experience is. They don't tell us why patients are experiencing this thing, how, where, or when, what events have led up to that experience happening. And that becomes very difficult then to act on. If I feed back to a surgeon that their communication score is 3 out of 10, then that doesn't really give them any actionable insight on how to improve. And it's exactly this that we wanted to challenge using machine learning. In the United Kingdom and elsewhere, many of these patient experience questionnaires have been expanded to include open text information, where patients can write a more qualitative summary of their experience of care. And the issue with this is, although humans can quite easily synthesize open text information in small quantities, when we release this across an entire healthcare system, it becomes completely unmanageable. So we've done a few studies where we've trained AI to do the same thing the human analyst was able to do. That is to take these open text comments about patient experience and doctor performance and to automatically classify them into meaningful categories. Here's an example of a tool called Open Text Analysis that you can find at the website here that takes a description of a doctor's performance that a patient or a colleague might make and automatically transposes that text into meaningful categories relating to their performance, such as whether the doctor was respected, innovative, or popular. At Brigham and Women's Hospital, we took this model a little bit further, and we wanted to really understand why patients who were attending surgical divisions within the hospital were experiencing the things they were experiencing. And we created a framework called the Emotion, Explanation, and Event Framework that allowed patients to report their emotion, to describe their emotion related to the care they receive, and also to tag the event that caused that emotion to occur. By imbuing this system with natural language processing, a form of machine learning for open text, we were able to create a meaningful and insight-focused feedback system for providers at the Brigham and Women's Hospital. We could say that because of your excellent care and professionalism, most of your patients are happy. In fact, 80% are happy. But waiting times and a lack of respect are the things that are frustrating people, giving clear insight into how things can be improved to improve patient experience. In the second example I would like to give, I want to talk about how we utilize AI techniques to create data-driven decision-making to drive individual care for women undergoing mastectomy and reconstruction. So machine learning can provide individual suggestions rather than an evidence-based medicine framework, which can suggest what is best for your population. ML can say what is best for the person sitting in front of you. And our question here was, could we use machine learning to accurately predict a woman's satisfaction with their reconstructed breasts prior to the initiation of surgery using data that we had previously collected? And this data came from an international study called the MROC study, which was conducted in North America. We collected breast-Q, patient-reported outcome measure information of women both at baseline, at 1-year follow-up and 2-year follow-up, and were really interested in comparing outcomes for women who had received implants or autologous reconstruction techniques. And we've been able to publish this work showing that we can have high performance in predicting individual satisfaction with the breast following different procedures, flap or implants. These predictions perform well and are valid at 1- and 2-year follow-up based on the minimally clinically important difference in the breast-Q. And what was really interesting about this study was that it gave us more insight into the current evidence. So the current evidence suggesting that flaps are always superior to implants, as you can see in the conclusion of this JCO paper. At 1 year after mastectomy, patients who went autologous reconstruction were more satisfied. We find that that statement is sometimes true, but it's not always true. And if you apply the AI we created to an individual woman who is consulting with you, then you might find that she would benefit from a different type of reconstruction. And what we can do with these complex nonlinear models is to interrogate the way in which they work by looking at how each individual variable contributes to the prediction. Here are two plots for the contributions for both improved and decreased satisfaction. Focusing only on the improved satisfaction plot, we can see here that having an implant with a tissue expander is associated both with improved and decreased satisfaction with breasts at follow-up. And it really depends on the woman that we are applying the prediction to. Thinking a little bit deeply about this and diving into the data, we were able to find that there were interesting nonlinear interactions occurring when women are rating the quality of their breast reconstructive surgery. And what we find is that women who have a low baseline level of satisfaction with their breasts, they tended to have a relatively higher level of satisfaction at follow-up. We hypothesize that this is due to having a reduction in breasts, which makes them more attractive to the woman who is rating them. And conversely, women who have a high level of baseline breast satisfaction tend to be relatively lower at follow-up, enjoying less the improvements that are created via plastic surgery. Now, alongside this nonlinear interaction is the simple fact that women who have lower baseline satisfaction are much more likely to receive a flap-based reconstruction. Okay, and we believe that it was this phenomenon that was driving the statistical model that was in the JCO paper to wrongly conclude that flaps were better for everybody. In fact, we found that even for women with low breast satisfaction, there are many cases where an implant will lead to higher satisfaction at 1 year and 2 year follow-up. So to conclude this study, we see that ML can accurately predict individual outcomes with using baseline data, and that we can interrogate these models to identify some subtle nonlinear relationships that were missed by traditional statistics. I think it really shows the opportunity for machine learning to provide evidence-based medicine at the level of the individual. And I believe plastic surgery, where many outcomes are subjective and will differ between patients, is an ideal place for this sort of new wave of evidence-based individual medicine to be trialed and deployed. I'm going to finish today's talk by talking about some risks of AI. There are indeed many risks of AI, too many to talk about in a short talk. They could lead to incorrect decisions being made and suboptimal care being provided. We are seeing evidence in medicine and in other fields, such as predictive policing and sentencing, that extant biases are being entrenched by AIs who are discriminating against different demographic groups. We can imagine that a robotic AI could malfunction whilst conducting a surgery, and there are plenty of people who are worried about malevolent general intelligence turning on us, and again, we are in the realm of science fiction. Today I'm going to talk particularly, though, about a risk that I see often, both in the academic literature and also in offerings that are made to companies like mine and possibly practices like yours. So we also look at AI for forecasting rare events. We are interested often in predicting things like complications and identifying patients that might be at high risk of a complication beforehand, so we can provide better care before the complication becomes problematic and before things like unplanned admissions occur. And I'm going to talk about some of the caveats of this approach and some of the pitfalls. So one of the defining things about predicting things like complications is that they are very rare, thankfully. And it's very difficult to predict rare events. You see, there are famous accounts of this happening in weather prediction, etc., or financial crashes, these sort of things. The rarer the event, the less of a precedent, the more difficult it can be to predict. Further issues in the prediction of rare events are created by the quality of data and also the content of data that is recorded within electronic health records. And despite the barriers, reasonable performance is possible, but real issues are also likely to occur. And I'll talk about one very important thing that we see very often, and I believe everybody should be aware of. Machine learning models natively assume a balanced distribution of events in a population. And if the events are balanced in a population, then something like a random guess about the classification will result in a 50% accuracy, and indeed accuracy itself will be a useful metric of how well the machine learning algorithm performs. Accuracy simply defines a number of mistakes that a machine learning algorithm makes and is expressed out of a 1, 0 to 1. So in the case of a 95% accurate prediction, we would say that the machine learning algorithm is pretty good. It's only made 1 out of 20 mistakes, misclassification errors, if our data set are balanced. In the case of an unbalanced data set, however, and this is a case when we're trying to predict things like rare events, mortality, or complications, then even a random guess could provide an accuracy of 95%. If I was to say that every patient you dealt with wouldn't have a complication, well, then I would be right almost all of the time, but that wouldn't be very clinically useful. And whether I say it or whether an AI say it wouldn't make it any more or less clinically useful. And this is something that is known as the accuracy paradox within machine learning, that when data sets are unbalanced and when predictions are made around things such as rare events, then the usefulness of accuracy plummets. But unfortunately, even in the peer-reviewed academic literature, we see modern machine learning studies falling prey to this accuracy paradox and claiming to have high accuracy, but when we interrogate their performance, then we see actually the algorithms are never correctly identifying the rare event that we want them to identify. So I'm going to conclude today's talk by saying that AI can currently, right now, perform many tasks across the spectrum of human ability. And although the AI we have is not the general sort of sci-fi AI that we may have in the future, it's still incredibly exciting. We can use it to make sense of unstructured data and capture data sources that we'd never previously used, perhaps like conversations or digital footprints that are left behind when people use the internet. Machine learning and AI can provide important insights into likely outcomes and facilitate individual level evidence-based decision making. And they can even go beyond traditional statistical techniques and find these subtle nonlinear interactions in data so we can always provide the best care to the people we are sat down with. However, it's worth remembering that many tasks are very difficult to do, especially when they utilize rare events. And the benefits of AI can easily be oversold, particularly by using summary metrics such as accuracy. I'd like to thank everybody who was involved in the MROC consortium for so kindly letting us use our data, as well as the members of the Inspired Cancer Care Group, particularly those who are focused on producing safe and effective AI for use in surgery and other oncologic disciplines. Thank you very much.
Brilliant. Thank you very much, Chris. Fantastic intro. Conrad, straight on to you.
Thank you very much. Hopefully I'm sharing my screen.
Not yet.
No. How's that?
Perfect.
Great. Well, thanks very much. And I just want to say that I'm really honoured to be part of the lineup here tonight, and to thank Rebecca, Shirley, and James Chan for developing this, fantastic forum. My name's Conrad Harrison. I'm a PhD student at Oxford University, and I'm interested in using data to understand how people think. I work with Chris and Jeremy on a number of projects that use psychometrics and AI to help surgeons and policymakers understand what's going on in the minds of our patients and then use those insights to help us make difficult decisions. And I've called this talk AI for Decision Support in Plastic Surgery, and I'll just highlight that before I begin. Decision support is not the same as unilateral decision making. People tend to imagine AI replacing humans or doing our job for us, but in my work at least, I see AI as a tool or even a teammate that could help us to make decisions, but not necessarily something that will make decisions on our behalf. So as plastic surgeons, we're involved in lots of difficult decisions. So for example, when this virtuoso violinist asks you what you'd recommend for this fracture and whether they're going to be okay, have a little think about what you might tell them. And what about this 12-year-old girl? Could you help her feel more confident like her friends? And what if her parents don't have much money and would need to pay for treatment? Would it be worth it for them? And how would you treat this calcaneal defect? These are all really challenging decisions, and historically, we would say that when posed with these decisions, surgeons were allowed to be in error but never in doubt. And you were kind of relied on as a professional to take a paternalistic approach and make that decision on behalf of the patient based on your experience. But in many parts of the world, that paternalistic culture has now shifted, and it's now actually okay to say, I can't make this decision on my own. And so now we have multidisciplinary teams to help share these decisions. So in the case of that osteomyelitis, the orthopedic surgeons and microbiologists might be able to help you come up with a management plan. And we've also got a wealth of published evidence and clinical practice guidelines that can support the choices that you make. And increasingly, we're trying to account for the patient's own values and involve them at the heart of the decision-making process, so that it's a shared decision with the patient. And this is one area where in the very near future, I think AI can help. And I'm particularly interested in the way that AI can empower patients in this shared decision-making process and help to make their voices heard. One way to capture the patient's voice in clinical decision-making is to use patient-reported outcome measures, or PROMs. PROMs are carefully validated questionnaires that measure elements of health like mood, mobility, or social function from a patient's perspective. And they can be very helpful to use in clinical practice because they allow you as a clinician to quantify a person's holistic health needs. So if a patient has filled out a PROM before you see them in clinic, you can use that information to see whether there's something that's particularly bothering them or whether there's an aspect of their health that they're more concerned about than other elements of their health. And you can also use PROMs to track a person's health over time, or assess the effectiveness of an intervention, or benchmark the outcomes of a particular surgeon or department. And there's now a large body of evidence that shows that using PROMs in routine practice improves patient outcomes, including survival in some conditions. But we don't all use them. And there's a number of reasons why. Sometimes clinicians and patients feel that these questionnaires are irrelevant or unhelpful, and they can be long and burdensome. So one example is the cleft Q, which is an excellent PROM for cleft lip and palate. And it can measure patients' perceptions of their facial appearance and social function, speech, psychological well-being, etc. And by using it in clinic, you could quickly see what aspects of someone's cleft are bothering them the most, or how your treatments were impacting them. And that would be great. But the problem is that the questionnaires' total length is 110 questions. And in many situations, it's unrealistic to get a child to complete that. But there is a way around this called computerized adaptive testing, or CAT. And CAT takes a questionnaire and administers questions one at a time. And after each question, a computer algorithm considers the answers that have been given so far, and then intelligently picks the next most useful question to ask. By using only the most relevant questions for an individual, CAT can make questionnaires shorter and more personalized, and in some cases more accurate as well. The technology was originally developed for aptitude testing, so I tend to use an IQ test as an example to illustrate how it works. We could start the test with a question of medium difficulty, and if the candidate answers correctly, we can estimate that they've got a medium to high IQ. And at that point, we can omit the easy questions, as they're likely to get them right too. And instead, we can select a question that would help to distinguish between someone with a medium or a high IQ. And every time the candidate answers a question, we can refine our estimate of their IQ and omit more and more questions, or skip more and more questions. And the cat will terminate when a pre-specified reliability or a time limit or a certain number of questions has been reached. And in the same way that IQ tests have easy questions targeted for people with a low IQ and difficult questions targeted for people with a high IQ, prompts have questions that are targeted to people with higher or lower levels of the measured health construct. So if we're trying to measure someone's physical function, we might have a combination of relatively easy questions, like can you get from room to room in your house, and relatively difficult questions, like can you run a marathon? But not all of the questions will be relevant to every person answering them. If you were taking a history and you wanted to understand what someone's baseline mobility was like, and you knew that they had trouble walking 100 meters, you wouldn't ask them whether they could walk a mile. You don't need to do that. You can guess the answer to that question based on what you already know. And CAT works in exactly the same way. It picks the questions to ask as if it was a doctor taking a history. And I think we all accept that taking a history is an important part of most clinical decisions. And you can think of CAT as a tool for efficiently adding more detail to your history with the minimum possible burden for the patient. And we actually built a CAT for the cleft queue, and we've used it in cleft clinics in Oxford and in Rotterdam. So when patients are in the waiting room, they get an iPad, and the questions are presented to them like this, and it takes most people about 7 to 10 minutes to complete. And before the patient comes into the consultation room, the clinicians can see the person's scores. So we could look at them like this, for example. This is a radar chart. So here we can see a patient's scores in each of the 12 cleft queue CAT measurement scales. So going around the clock face from 12 o'clock, we have appearance of the face, speech distress, speech function, psychological well-being, and so on. And outwards here means a clinically good score, and close to the center means that person is perhaps less happy with that aspect of their health. The patient scores are in purple, and in red, we have the scores that we might expect for someone with similar clinical and demographic characteristics based on population studies. So for this person, before they even enter the room, we know that their speech function is a bit poorer than we'd expect, but this doesn't seem to bother them too badly because they've got a good speech distress score. We can also see that they're perhaps a bit more concerned about the appearance of their nose and nostrils compared to what we might be expect. And that could help us to rapidly focus the clinical conversation. We might want to look at one element of their health in more detail. So for example, here you can see that a face appearance score of 64 would put you in the 84th percentile of females aged 16 to 19 born with a unilateral cleft lip and palate. And if you want to try this out yourself, I've left the URL to this web app that we've made on this slide. We interviewed patients and clinicians about their experience of the platform, and here's what some of the patients have said. It helped me be more honest about what was bothering me. It helped me mention things I didn't really want to mention. It makes it easier to talk about what you want to talk about. That questionnaire compared to the paper one I've done in the past, they were similar, but it was more about how I felt rather than other people. And that's a really interesting quote there, because I think what they're getting at is the adaptive nature of the CAT algorithm and its ability to pick only the most relevant questions for a respondent. And from a clinician perspective, we found that the platform helps us to focus on a patient's concerns. It can streamline the consultation. And as a screening tool, it's even triggered referrals that we don't think would have happened otherwise. For example, by picking up psychological issues during routine dental appointments. So AI can help us to understand what patients are thinking when they come to see us, but sometimes patients also ask you to predict what they'll be thinking in the future. It's not uncommon for people to ask, will this operation make me feel better? And this is a really difficult question. They're not asking, will the bone unite or will the infection resolve? They're asking whether from their perspective, they will experience a change that they value following treatment. And to answer this question, first we need to be able to see into the future, and then we'd need to be able to read their mind, and that's impossible. So instead, to answer this question, surgeons use their experience, judgment, and any published evidence that they've read to help us guess whether the patient is going to feel better or not. And often we can guess that correctly, but sometimes we get it wrong. And in the near future, AI might be able to help us make those guesses more accurate. Carpal tunnel decompression is a good example of this. It's a very common operation. In the UK, about 1 in 1,000 people have a carpal tunnel decompression each year in the hope that it will relieve sensory or motor symptoms. But 25% of people that have this operation don't feel better off for it. And in fact, about 8% of people actually feel worse. And that's a problem for surgeons because we're exposing patients to the risks of surgery, and a quarter of them are not going to think that you've made them any better at the end of the day. And at a societal level, it's also a problem for taxpayers and insurers because we're spending a lot of money on operations that are not necessarily worthwhile. So we recently ran a study with collaborators at NHS Fife to see whether it was possible to predict which patients were going to report a meaningful improvement in either sensory or motor symptoms following a carpal tunnel decompression. We had access to a data set of about 2,000 patients who'd undergone the procedure since 2010, and we used a range of clinical, demographic, and patient-reported data to create machine learning algorithms that could predict which patients would report a meaningful improvement in sensory or motor symptoms. And the idea was that if you had this technology in clinic, it would help you to manage expectations or even pick the right patients for the surgery. And this is how we got on. These are receiver operating characteristic curves, and they show you the trade-off between sensitivity and specificity. So they basically tell us how good our algorithms are at detecting people that will improve, that's sensitivity, and how good our algorithms are at ruling out people that won't improve, which is the same as specificity. And as with all diagnostic tests, we have to find the right balance between sensitivity and specificity. You don't always get both, particularly when you have class imbalance, as Chris was talking about in the last talk. On the left, we have the models that we trained to predict an improvement in sensory symptoms. Each colored line is a different model that we tried. And on the right, we have those that were predicting an improvement in motor symptoms. And generally, the models that get close to the top left-hand corner in each graph are the best performers if you're looking for a compromise between sensitivity and specificity. Overall, the computer could correctly predict who would get sensory improvement in about 76% of the time, 76% of patients, and it could predict who would get motor improvements about 72% of the time. And what this means is that AI may be better at answering this question than a human hand surgeon. And in our cohort of patients, the computers were achieving a better trade-off between sensitivity and specificity than what we'd expect from standard practice. And humans working with AI may make even better decisions than either working alone. And we're not quite there yet. There are a few issues that we need to address before we can bring this kind of AI to the clinic. If you've ever worked as a junior doctor in the NHS, you're probably thinking that this kind of technology is totally unrealistic. I mean, it takes half an hour to find a working printer. And another issue with these algorithms is that it can be difficult to understand exactly how they're making predictions and whether you can trust them. And one way we've tried to address these issues is by simplifying the machine learning algorithms right down into flowcharts that you could print off and laminate and stick up on your wall in clinic. In this flowchart, which predicts sensory symptom improvement following carpal tunnel decompression, we have some gray circles which represent different questions that we might ask the patient preoperatively. We have straight lines which tell us which questions to ask next based on someone's responses. And at the bottom, we can see the patient's chance of improving with surgery. Now, this diagram is a bit difficult to interpret, so let's just focus on one path for the moment. According to the flowchart, you could start by asking whether the patient has a difficulty sleeping. And if they say no, then we ask what their pain is like. If they have severe pain, then their chance of benefiting from surgery, the green portion of this bar chart, is about 0.16. Or in other words, based on our data set, if you have severe pain but no difficulty sleeping, there's only a 16% chance that your sensory symptoms will improve after a carpal tunnel decompression. Perhaps your pain isn't actually caused by median nerve compression at the carpal tunnel, as that tends to be worse at night. And maybe for this patient, we should think twice before listing them for surgery. Or your patient may report severe difficulty sleeping, and then they might rate their general health as good overall, so over 90 out of 100 points on a visual analog scale. In that case, they have a 93% chance of sensory symptom relief following surgery. And by using some clever machine learning techniques, we can arrange these questions in the most efficient way possible. And you can see here that just from 1 to 2 questions per person, we can cover the whole spectrum from people who are unlikely to improve, so the bar on the left that's mostly red, through to people who are very likely to improve. For example, those bars to the right, which are mostly green. And we get similar results for predicting motor function improvement as well. And how do we know which questions to ask? Or we could just follow the flow chart when the patient comes into clinic. Or better still, we could use computerized adaptive testing in exactly the same way that we do for cleft lip and palate. So even before the patient walks into your clinic room, AI can help us to understand the elements of health that matter most to them and what the consequences of different treatment options may be from their perspective. And we can then discuss this information with the patients and combine it with our own clinical experience, advice from our colleagues, and recommendations from the literature so that we can make even more informed and more patient-centered decisions than ever before. So that concludes my talk. And I just wanted to share this last slide in case this evening inspires anyone to go away and learn more about AI and machine learning. These are some of the papers that I'd really recommend. The first one's a really nice clinical introduction that covers some of the most important concepts in AI that are relevant to surgeons. The next two are good papers for people who want to perhaps invest a little bit more time and learn some of the programming. That second one that Chris has written has been downloaded over 30,000 times. And it honestly isn't just me and Chris downloading it. And if you want to know more about using AI and PROMs together for decision support, then that fourth paper has some quite interesting examples as well. And you'll be able to look these back up from the recordings. That's it from me. Thanks very much.
Thank you, Conrad. That's brilliant. Look, thank you, the two of you. Congratulations on giving such eloquent talks. You've kind of conveyed very difficult concepts and made them very palatable and understandable. So even someone like me could understand. So thank you. I could sit here all night asking you questions, but there are questions already from the floor. But just to get things started, I wondered whether I can ask Chris, and we'll have Jeremy come in as well because he hadn't given us a talk, but just to join in the discussion. And to start with, Chris, I wanted to just bring you back to a comment you made, which I found fascinating. You said humans tend to think in a linear fashion, and that was always something that I thought that we many of us actually differ from machines, in that we actually learn in a very non-linear way. I thought that we can think cross-disciplinary, and it's the kind of thing that Malcolm Gladwell talks about in Blink, that we make decisions that may appear irrational, but because we have so many different experiences, we can't necessarily articulate all those decision nodes.
So yeah, it is very difficult to delineate exactly what's happening when a human thinks, and I'm sure there are some non-linearities there. I'm thinking perhaps over the course of like a career or, you know, a period of time, then we use strategies to make our thinking like more simple, right? Heuristics and these sort of things. And I think in that sense, we can think of it as being kind of linear. Like we apply simple rules to everything, right? Because it's just the way we tend to work. And AI can, I think, be used to kind of break some of those simple rules that we use.
Okay, Jeremy, did you?
Well, you know, I'm going to say something provocative because they've been great talks, but it's late in the evening. I'm going to say that you two guys have chickened out. And I'm going to say that you two guys just give too much credit to human thought. You say that, you know, AI may be able to support or work alongside the human brain. I'd say the human brain doesn't make linear decisions. I think it makes terrible decisions, usually, really, really poor. And I think clinicians are really, really bad for being completely arrogant about their decision making. You know, Chris, you put up a mammogram with a breast cancer, and we're talking there about the possibility of AI algorithms predicting whether there is a tumor or not. You're a typical radiologist, and I can say this because both my brothers are radiologists, is influenced by the fact that his toddler, like mine upstairs, didn't sleep last night, maybe had a bit of a heavy Christmas party the night before. He missed a breast cancer last week. So this week is going to be a little bit more cautious. It's biased all over the place. And not all of those inputs, not all that experience is helpful. Whereas some of these algorithms, they click through completely reliably, rock solid, like clockwork. Conrad, you said, you know, that these can work alongside, and perhaps clinicians working with AI can be even more powerful. Well, what if the clinicians are holding back AI's potential? So I don't know, do you guys want to comment on that?
I think one of the things we use as clinicians to make decisions is a sort of gut instinct or a judgment that's slightly intangible, that's based on many, many cases that we've seen throughout a career. So if you're thinking about, let's say you're an orthopedic surgeon and you want to try and decide whether someone's going to benefit from a knee replacement. You might have seen a few hundred knee replacements during your time at medical school. Then as a junior doctor, you might have seen a couple of thousand. Maybe you've seen 10,000 during your specialty training, probably not, but for the sake of it. And then you're a consultant for, 20 years. Over the course of your lifetime, you'll maybe have seen 100,000 knee replacements, but probably not more than that. If you look at the National Joint Registry, there are well over 1 million recorded knee replacements and hip replacements. And that data far exceeds what any individual would be able to have amassed over the course of their career. So, you can make decisions using AI based on a much greater caseload than an individual would have had experience to. So, in a way, you're right. But in a way, I disagree. I think you do need the human there, because at the end of the day, the buck stops with the doctor, and you need some sort of accountability for these difficult decisions. And, patients like to speak to people, human beings, and put trust in another person sitting there. I think bringing AI into the way that you're suggesting is a little bit difficult.
I'd agree, and I think in theory, AIs could do far better. So most AIs that we can train now, we train utilizing the same data that a doctor has seen. Perhaps it's come from the electronic health record, so the machine knows the same data as the human, right? In the future, it's possible that we could train a machine on a far wider corpus of data than a doctor would ever have access to. You could have in-depth knowledge about the person's movement from their GPS phone for the past 10 years. You forget about taking an individual history. The algorithm can read everything off a person's phone and have all of that information. So I think it's certainly possible that much, much, much better decisions can be made, and they'll start to be made when the kind of information we are feeding into these algorithms is way beyond the sort of information that we could ever convey in a, we should all sue Conrad in a simple clinical
Jason Wong's very cynically put the point there in the chat that you can't sue a computer, which is exactly the point I'm making.
I think there's just one point I think is fascinating is the way humans deal with machines and humans when they make mistakes. Right, tens of thousands of people die in human-based car crashes every year without really much uproar. But I think, if there were 10 AI cars that were to kill someone in a year, even if they were normalized for the amount they were used, there would be uproar. And the same with the surgery. I think patients are terrified that a Da Vinci machine will go wrong and cut them in half. But it just seems much worse than the risk of a human doing it. And there's something in that, I think.
If I may, one of the things that's fascinating is that we are now at a stage where we're getting quite good at the narrow AI, as you were saying, Chris, and we're not so good at the what's the other terminology?
The general
AI. But we can all foresee probably that we'll get there at some point. But one of the things that Roger Penrose, for example, the mathematical physicist at Oxford, keeps talking about is that he thinks AI will not have wisdom, however you define it, and reasoning ability. And I'm just thinking, in the future, when we get to generalized AI, are we going to get if the algorithm spits out a decision, will we get a reasoned decision? You think? And is that going to be something that takes into account the patient's well, it will take in perception of the patient if we're using cats, for example, like Conrad was saying. And finally, is there going to be a kill button? Because everyone talks about that in AI, don't they? To kill the algorithm if something unpredictable or disastrous happens.
Yeah. So I think that we should always have a human in the loop to make sure that decisions made by AIs are, on the face of things, sensible. The inclusion of patient-reported data, I think, is absolutely important. Because just as schemes like value-based healthcare from the Harvard Business School say that if we include patient-reported outcomes in an economic model for healthcare, then we can't have misaligned incentives because we are improving the patient's own perception of health. The same thing for patient-centered AI. You know, if the AI is designed to maximize a patient's perception of their individual care, then there's far less risk. I did a talk years ago about how, you know, we could harm patients a lot by optimizing around sort of waiting times and ignoring people who are going to have too long of a waiting time, for example. So we needed to focus on the patient outcomes.
Right. So shall we invite some of our guests to come up?
And I just ask a sort of, I've got so many thoughts in my head that it's hard to put them into a kind of coherent question, but I'm interested just to know about, you talk about an algorithm where you just home in on certain things, but there's just so much. So there's personality, there's cultural background, there's quality of the surgery. Neither of you have mentioned that. And I'm also interested to know, if your patient likes you, are they going to do better?
So I think, you know, I think these are all really important points. And I think where they touch on is actually some of the generalizability of what we're looking at. So for example, what Conrad presented there is effectively a data set from, you know, a very narrow practice. There's a large data set in Scotland from largely one surgeon. So that's prediction of the outcome for an operation performed by that surgeon on that surgeon's case selection. And, you know, I do actually think that there is this other challenge there. So first of all, that might not always apply to everybody else. That might not apply to carpal tunnel release in general. And I think we need to test that. And I'd be interested to see what Conrad thinks about testing, generalizing, and being confident that you could deploy that across, say, the whole UK or UK and America.
And for example, could I employ that for my wheelchair users that need carpal tunnel decompressions? Would that perhaps be a completely separate group?
So if I jump in, we have different levels of validation for these algorithms, and the most basic form, you test how it's performed on your own data set, and that's the internal validation. And then a slightly better form is to test it on somebody else's data set, which is external validation. And generally, when people are publishing this kind of thing, they do the internal, external validation. They say, off you go, here's our algorithm. Please feel free to go and use this in clinical practice. But that perhaps actually isn't good enough. And when these things are being scaled and deployed in real life, it's one thing to know that the algorithm works fantastically in an external validation data set, but actually the important question is, does it work for your patients in your clinical practice? And the key, I think, in the future will be a learning healthcare system where the data are collected and they're incorporated into the model, and then the model makes iterative adjustments to improve its performance in a given setting. And that's really important. The other interesting thing maybe to touch upon is that there's this phenomenon called data set shift, where you might develop an algorithm that works fantastically, but then the nature of the input changes over time and the algorithm doesn't work so well. So a good example for that is predicting sepsis in hospital, bacterial sepsis. A few years ago, having a fever was an excellent indicator of bacterial sepsis. It was a very powerful predictor. But then COVID happened, and all of a sudden, having a fever isn't particularly discriminatory anymore. You know, that doesn't really indicate bacterial sepsis. It's probably just COVID. And accounting for the ways that data sets can shift is very, very challenging. And that's something, you know, the way around that, I think, is to continuously update these models with site-specific data when they're deployed.
Great. So I'd like to bring in some of the participants. I think Gabriella Mazzoni, she's had a couple of really interesting comments, and it would be great if you can join us as a panelist. So I've promoted you to panelist. Let's see if Gabriella will come on. Hello, Gabriella.
Hi, everyone.
Welcome. Can you tell us where you're calling in from and what you do?
Yeah, of course. I won't put my video on because I'm in London, so it's quite late and I'm in my pajamas. But I'm a medical student at Guy's and St Thomas.
Great. So thanks for all your questions and comments. Can you let's bring the discussion here. Tell us what you're thinking.
Yeah, of course. Well, first and foremost, I think these technological advances are incredibly exciting. In our lectures at university, we learn a lot about personalized medicine and, you know, making sure that the patient has a very personal experience to improve outcomes for them. For me personally, I do kind of wonder whether a patient will be able to trust their own thoughts and feelings over those of a computer. And that's sort of based on how I would approach the situation. And I've had some responses to my questions, which say that on balance, it's better to give them, you know, the support of the AI, but that's something I'd still be concerned by.
Well, let's develop that a bit more. Jeremy, can you jump in here?
Yeah, I don't know. I mean, I think sometimes I maybe sound like a broken record on this, but I think we make this as if we're comparing kind of apples and pears or something. That, you know, we're both talking about here a human brain and doctors, and we're talking about AI. Both of these are just systems for making decisions, right? I mean, so, you know, to go back to what Rebecca's already said, well, you know, does the Scottish carpal tunnel data apply to her practice now in Buckinghamshire? Well, what if you as a surgeon trained in Scotland and then suddenly ended up with a consultant job in Buckinghamshire? I mean, Rebecca, I don't think you necessarily had done lots of spinal injury patients, carpal tunnel releases before you suddenly became a consultant and had to try and advise people based on experience elsewhere that was arguably as irrelevant as the training data set for the carpal tunnel prediction. We just seem to assume that we have this entrenched assumption that the human approach must always be better to begin with. And I think it's often subjected to exactly the same biases. Chris said that the human mind knows the same data. Well, actually, I don't think they do. I'm not really sure the surgeon has looked at 2,000 patients' outcomes. And I think, you know, we need to probably also encourage patients to be more open-minded about this. This is actually something that will listen to you impartially. It won't be looking at its iPhone, checking, you know, the clock behind you. The AI will actually listen to you and truly relate what you're saying to other people like you. And hopefully, I think, you know, be able to increasingly do that even if you're in a relative minority. And I think that, you know, Chris alluded to that as a challenge. I think that is definitely a challenge. But, you know, I think we focus on improving that. But I do think if you know, most of the criticisms are at a level that AI can also just be level that human decision-making as well. We just choose not to. We just arrogantly assume that human decision-making is better, more emotionally connected somehow, when I think it's actually not.
Chris, have you got some comeback to that?
I think I'd agree. I often say and ask my friends, you know, do you think medicine now is as good as it can be? And lots of clinicians I work with say, yeah, it's fantastic. We've made incredible progress in cancer outcomes. But like in the work I do more generally in oncology, you know, there are terrible reactions to most treatments. A lot of treatments are ineffective. We can't necessarily tell when they'll be effective. We don't know about long-term sequelae for patients' quality of life and their experiences. And all of these things are things that could be improved at least somewhat using AI, right? By collecting more data, by having more information to better characterize patients' lives before they interact with health services and understand what happens after they've interacted with health services, I think will give us much better information to improve the quality of healthcare in the future.
And if I may just jump in here, I mean, one of the things that puzzles me is, you know, it's great to have cats and all these questions, but then we must be informed by meaningful questions. I mean, it's all very well asking if the patient feels better, but as you alluded to, Conrad, what does better mean? I mean, the patient might have a better quality of life, but actually their life expectancy is much lower, or vice versa. And how do you then decide how much onus to put on the different various domains of what feeling better means? You know, and so in many ways, we are bound by our own values and, you know, everything that makes us human. And I don't know how we square that in a completely non-emotional, machine-driven healthcare service in the future. Conrad?
Yeah, it's a great point. I don't really have a definitive answer to that, but this is where the fields of health economics, understanding what people and society value most with regards to their health, and psychometrics as well, understanding the outcomes that matter most to the people, to your key stakeholders, and how to measure them accurately. And, AI isn't going to be successful if it doesn't take into account those other fields. There has to be interface work where we're integrating those different sciences.
So you mentioned psychometrics. Can you just, for the audience's sake, explain a bit more about that?
So psychometrics is the other thing that sort of Chris and Jeremy and I are interested in. It's the science of measuring constructs that exist in people's minds. So measuring something like temperature or weight is very easy because you can directly observe it with a thermometer or a set of scales. But in plastic surgery, we're more interested quite often in improving someone's quality of life, in their social function, their self-esteem, their perception of their appearance. And those can be very difficult outcomes to measure. So psychometrics is the science of measuring those constructs as accurately as you'd be able to measure temperature or weight. And we do that through a set of probabilistic models. So it's the sort of interface between maths and psychology, and it can be applied to outcome measurement in plastic surgery.
Mm-hmm. Great. Gabriella?
Very interesting points raised. I think one thing I picked up on was the danger that we have as clinicians, and future clinicians in my case, of unconscious bias. And I was reading a bit of Paul Bloom, and he writes an argument against empathy, in which he says that you're never going to be able to mirror all of your patients' experiences. And I suppose having such extensive data would overcome that.
Yeah. Great. Okay, well, we'll leave that discussion there. Thanks very much for joining us. So we have Jason Wong, who's a regular attendee and making lots of provocative comments up here. So I'm going to invite him to come up. And hang on, let's just change role to attendee. Jason, you are up. Good evening, Jason. Come on then, bring the fight here.
Oh, I'm not a fighter. No, it's a very interesting discussion, and I suppose I'm just a novice in this area, but very interested and an avid fan of the Terminator films, so very interesting to see where the direction of this work is going. I mean, my experience of AI has been that it's very good at simple tasks, feeding in lots of information and developing algorithms that will effectively be learnt through patterns. And I suppose the limitation, or I perceive there being a limitation when you have multifaceted problems, multifactorial, that's a combination of both physical, psychological, and temporal elements. And so where clinicians would normally use time as a factor to get to know the patients, understand the patients, and understand these complex problems, how do these decision algorithms deal with that kind of information? And can it be used to combat really rare, really one-of-a-kind problems to give you a reasonable readout? And that's aimed at any of the panelists.
I think it needs to be a fair comparison, like a fair fight, right? And like you say, some clinical scenarios, you might build a rapport over a long time, assimilate large amounts of data by continuously going back in multiple consultations, confirming your assumptions about how somebody thinks, so on and so forth. And, maybe it's a little bit unfair that we're trying to ask an algorithm to do that, on the spot. But nevertheless, how do this? I mean, Rebecca and I work together, right? And we often see patients together. We're completely different people. Everything from, we look different, our backgrounds are different, we think differently. And I tell you now, we put two patients the same patient in front of the two of us, and we'll give you two quite different answers. And we actually really value that, you know, or at least I certainly do, because she definitely challenges my thinking. And you know, there'll be bits that she's picked up on in the conversation that I say, oh, I didn't really think about that. And I try to refine what I'm doing. And I just wonder whether actually, you know, we have our own blind spots, right? We have our own Johari windows. There are bits that we understand about how we think and bits we don't. And I just wonder, you know, if these kind of algorithms, if given the opportunity to train on the amount of data that you're talking about there over time, can actually get better. I wonder if we're actually, you know, the AI is, it's you know, first year medical student, man, you know, give it a bit of time here. It's just getting going. And I think, you know, sometimes we're being a little bit harsh on you know, the comparison then. I don't know, but maybe I'm biased here.
One of the things I wanted to ask you guys is about the you know, deep learning. Where are we at with deep learning in healthcare, particularly because that will be the key to helping us, helping AI answer some of those addressing some of those complex problems. And is the limitation the fact that we haven't got complex enough algorithms yet for deep learning, or is it the lack of data we have? What is it?
So deep learning has been driven by social media companies, essentially, who have an incredible amount of data. We have not a fraction of that sort of data within a typical electronic health record. So whereas we might be using deep learning for things like image recognition, images of course create much more complicated data when they are, you know, sort of transferred to ones and zeros. But for decision making, we just simply don't have enough data to make use of like deep architectures.
And would you just explain what deep learning is for people who are new to the field?
Sure. So it's essentially just an incredibly big architecture that can deal with like masses and masses and masses of data. We're talking about data which are billions of rows wide and deep, like the sort which may be generated from like Google's operations, for example. And they're very good at finding subtle patterns in incredibly huge data sets like that. Unfortunately, there is just nothing of that sort that we have in healthcare. And in fact, what we find is that many salient relationships in healthcare are reasonably straightforward and linear. Right? If you smoke more cigarettes, you have a higher risk of all sorts of health issues. There is no sweet non-linear sweet spot of smoking 10 cigarettes a day and your outcome will be better. So what we find is that we just don't see a massive advantage from using much more complex machine learning architectures. Again, this is something you can see quite clearly in the papers Conrad and I have written. That fairly simple architectures work fairly well with the data that we have, because the data we collect right now is pretty simple. It's pretty straightforward. So
Jason, would you give? Are you willing to give AI another few years before, you know, seeing how?
No. I mean, I'm definitely an early enthusiast. I'm an early enthusiast with everything, but the proof is in the pudding, isn't it? And you know, I suppose for imaging, and suppose for kind of reading outcomes and giving readouts for patients to, you know, look after themselves, for example. I think that's a very powerful and useful, available now tool. It's just, how will it evolve in the future, and will it take over all of decision making? I mean, that's the danger, isn't it? Yeah. It takes over all of decision making and makes us technicians. Yeah. And so is if that's the case, it might make my life a lot easier.
It might allow you to focus much more on interpersonal aspects of care that patients really value. Right, all the difficult stuff, like your job becomes helping somebody make decisions utilizing all the data you have. Like I think a great example of like how AI performs now, like if we think about the mastectomy reconstruction work that we did. So a well-informed clinician will say that has read the JCO paper that women do better with flaps. So if you have a flap, you'll be happier. Our data shows that's not true. So even using the algorithm that for everybody, you know, even using the most basic algorithm we have now, we can overcome best practice by making best practice even better. In the future, and the algorithm we're going to develop is we ask the patient, what do you prioritize in the future? A mix of satisfaction with breast, functional impairment, cost in the United States. And the algorithm, I don't think any clinician could say, okay, if you really want all these things to be optimized in this particular way, this surgery is best for you, without massively guessing. But the AI perhaps has, 400 people's data who have exactly the same, surgical characteristics and represent the outcome that the patient wants. So I think even now there's massive advantages for some of these things.
Do you think autologous breast reconstruction will go out of favour?
I don't know. I wouldn't say that. Well, I don't know, actually. It's a little bit difficult to understand exactly what's going to happen there. It does look like implants are pretty good, better than they appear. And there were some big problems with the earlier statistical analysis that really showed that flats were better. It looked like, to my mind, what happened there was bigger women had flaps. Bigger women felt better because they had a reduction as part of their reconstruction. Most of the time, but not all of the time.
We've gone on quite a long time, so we are going to need to wind up the evening shortly. I think we've probably got time for one more question. Thanks very much, Jason. Really appreciate you coming on. So Oscar Fernandez had a question. Is he there?
Yeah, let me just
be a good one to finish off. I mean, it's a fascinating subject and we would love to talk for longer, but we do need to bring it to a close at some point shortly.
So Oscar is a consultant plastic surgeon from Mexico. He's recently gone back from childhood, I believe.
Hello, everyone.
Hi.
Hi,
thank you so much for the kind invitation. Congratulations to everyone. It's a great talk. And my question is with regards which area of the plastic surgery do you guys think would be the one that AI will have the most impact? Because, it could be burns, it could be facial palsy. You guys are working with hand surgery, breast recon, skin cancer. Any thoughts?
I think there are so many different applications that it's very, very difficult to compare them across the spectrum. We're using AI quite a lot in genomics and genetic studies, and they obviously have a huge potential impact for plastic surgery. They might unlock the key to scar-free healing, perhaps. You've got your cancer genetics there as well. And then there's 3D bioprinting and, modeling sort of cellular architecture that can be supported with AI. For me, though, coming from the psychometrics background, I'm going to say that it's in measuring patient outcomes and making personal decision making, because one of the key differences of plastic surgery to many other specialties is that most of our procedures are there to improve quality of life, and to do that correctly for different patients, we need to really understand what they're thinking, their values, and whether or not we're going to make a difference to the individual person. So that's what I would say. I don't know, Chris and Jeremy, what you think?
I'd agree. So again, I work across lots of different specialities, and I think plastic surgery is one of the most exciting for AI, but for that reason exactly. It's about maximizing a kind of difficult thing to understand, quality of life. I think AI, particularly in combination with psychometrics, and no doubt this is our background that makes us more kind of aware of these things. I'm sure there are other problems that AI could be incredibly well applied to. Really represents like a unique opportunity within health services. And I think that's pretty amazing.
So, I mean, I agree with what the guys are saying. I think, though, having spent half of this evening arguing back and forth about what's superior, the human brain or AI, what about AI in the areas of plastic surgery that, frankly, we're just not either equipped to do or get round to do? So Chris had that picture of all the piles of paper everywhere, the stuff that you're just not going to manage. So I think that the kind of areas where it could really impact are where we have inequity of access and hidden kind of voice. So I noticed Rakshan Cameron's in the audience tonight. Rakshan's, shout out to Rakshan, he's just joined our team in Oxford, having come across from Canada, to look at deploying gender Q and gender affirming care in the NHS. Now we've got relatively limited gender affirming care service in the UK, and enormous demand, completely unmet demand. It's like a tsunami that's held back. And frankly, I don't think we'll ever have services set up in a way that will be able to cope with that. But this is where AI could actually potentially help to streamline and provide appropriate access to care in a more equitable fashion. So I think it's these kind of areas where demand outstrips our services, and we need to have something to help us get the people who are going to benefit most in a fair and objective way. So I think, for example, I think watch out for the outputs that are hopefully going to come next couple of years from what Rakshan's up to, because I think that's going to be really interesting.
Can I challenge you on that though, Jeremy? In those areas where there's not much, there's inequity and to access and so on, there's going to be even more limited data sets for that.
Yeah, the data sets are limited, but again, I think the challenge will be to start measurement, to start building data sets, and also to bear in mind, well, what are you comparing it to? What you're comparing it to right now is, you know, a bit of a dog's dinner of access, to be honest, you know. So even with limited data sets, with you know, caveats and problems, that is likely to still be an improvement on what we're doing at the minute.
Mm-hmm. Oscar, you satisfied?
Very satisfied. Thank you so much, guys.
Great.
Thank you. Thanks for coming on.
Just posted one link on the, I know we're running out of time and I won't take much longer, but we've had a really important question about bias in AI. And this, you know, racial bias and other forms of bias have become a really, really hot topic now that we haven't really touched upon this evening. And I've posted a link to a paper that was published in Science that looks at dissecting racial bias in AI algorithms. And I'd encourage anyone who's interested to have a look at that paper and learn more about it there, because I think we've run out of time to talk about that tonight.
Thank you, Conrad. It's been a wonderful discussion. Thanks very much, Chris, Conrad and Jeremy. We really appreciate you coming on. It's been a really lively discussion, and thank you all.